Hello everybody. I'm going to get right into the lecture today and get you ready for the quiz. So we're going to start by talking about fitness and spinal cord injuries. What happens to individuals who have spinal cord injuries is a reduced amount of fitness or more sedentary behavior. Why? Well, most of the time it's because they're not able to move as much. Have the inability to use parts of their legs, arms, whatever it may be. So they're definitely going to be affected through just not having many opportunities sometimes, not being able to play sports with friends if you utilize a wheelchair, but maybe being fully functionally, in your upper body. So maybe being able to play basketball or throw a football or, get into rowing or something like that. So individuals with spinal cord injuries, you may see obesity. They might have a general level of fitness that might be a little bit lower. You want to emphasize, working out, really. Flexibility is key because you're going to have limited range of motion because of your limitations. So you're going to have to, the parts of the body that you do have, you're going to want to have more range of motion. Strength, you're going to have to do more. You're going to have to be able to, maybe pick yourself up out of your chair and lift yourself onto a bed. So you're going to have strength to do that. You're going to have endurance. Propelling a bike, half a mile is a lot different than walking a half a mile. So you're going to have muscular endurance as well. And you have to be able to deal with muscle imbalances. One side of the body might be a little bit better than the other side of the body, and you're going to have to learn how to balance those. The Brockport Physical Fitness Test, we've talked about this in class. If you've never seen it before, I have posted it on your lab, but really the best way to find anything is to just type it in and press PDF, and you'll typically find almost any article or test or anything like that. And so this is a good guide, the Brockport fitness test. I actually went to Brockport as an undergrad and actually took their adapted physical education course with Dr. Lieberman. But I won't go into more detail about that. But this is a great test. If you are looking for more assessments for your mentees, these are a great go-to guide to look at different things that you can do, assess, and really just understand somebody's motor pathways and development. So after that, we're going to go ahead and get into fitness and safety. So hypotension, thermoregulation, autonomic dysflexia. So hypotension is having low blood pressure. Sometimes having impairments in the limbs also affects the nerves, and so sometimes that can also create lower blood pressure. Thermoregulation, that's controlling the heat in one's body, so sometimes that can be affected. So sometimes getting too much blood in a certain area of the body isn't a good thing, so you have to make sure that they're thermally regulated. And then autonomic dysflexia, which can be all sorts of issues with blood pressure. So it can be a sudden increase of blood pressure, and that's important because it can occur faster, quicker with individuals with spinal cord injuries. As far as other things we want to look at, spinal column deviation. So we've heard of these terms: scoliosis, kyphosis, lordosis. Spondylosis and is defined as a defect or stress fracture in the pars interarticularis of the vertebral arc. So the vast majority of cases occur in the lower lumbar, but spondylosis may occur in the cervical vertebrae. So it's basically a stress fracture in the vertebrae. Then we have spondylolisthesis. Sorry, I can never say anything. And this is a slipping of a vertebrae, and this is typically at the base of the spine. And It's similar to spondylosis, which is the defect or fracture, but they can both, be in the vertebrae and can result in, vertebrae slipping forward or backward, or bone or below. So these can be issues for individuals with spina bifida. As far as treatments for spinal deviations, first we want to establish policies and procedures. We'll work on strength and flexibility like we talked about earlier. You want to make routines fun and motivating. A lot of times these individuals are not that motivated because of the perception toward them that they can't do anything. So you actually have to try to motivate them and have fun, because a lot of times, and the individuals I've worked with spina bifida, so I know this firsthand. The individuals are very timid. They don't have. Doesn't mean that you have an intellectual disability if you have spina bifida. So spina bifida is when your vertebrae grows outside of your body when you're born, and so this affects your legs. Most individuals have very little to no movement in their legs. So, not having an intellectual disability and having to utilize a wheelchair, you know, you get the stereotype of, having an intellectual disability, because most people think those are just co-occurrent, but it's not always the case. So just because somebody is utilizing a wheelchair or has an amputation, it doesn't mean that they're going to be unable to perform. Um, and so treatment is really important, and employing appropriate warm-up and cool-downs is also important as well. You want to emphasize static over dynamic stretching. Um, that's something that I'm kind of interested in. Why would they suggest that? I would think because the dynamic stretching might cause more stress, and so maybe that's why they emphasize the static. Integrate programs into the regular physical education program. Um, you know, Involving fitness, sports, any type of thing that might get them motivated. Make sure students understand they can do the exercises correctly. Overhead shoulder press, battle rope, football throw, rowing. Those types of things should be fine. Encourage students to watch themselves in mirrors when they exercise. That'll be important, because sometimes there's going to be a lot of balance issues, as far as sitting in a chair, or just in general having to use your shoulders more than your hips. So those are going to take a lot of the brunt of most of the work that you do. Other treatments, you want to make sure a program is followed outside of physical education. So a lot of times, we teach these individuals, but they might not take it home, and that's why I think it's important for us to create these lesson plans. And I want, this is what we'll be touching on in the next couple of weeks, but we're going to have you give your lesson plans to the mentees on that last day. Depending on your lab, not all labs are the same, but we're going to try to give them some type of guide to take outside, of the classroom. Emphasize symmetrical exercises and be aware of limitations imposed by braces. That's important because sometimes the braces can get in the way. If you're going to try to get them, let's just say, in a tricycle, just to get them hips mobilized, it might be hard to get them in the bike because of the braces. Sometimes the braces have to come off before swimming, so you might have to take the braces off yourselves. And there's lots of limitations as far as range of motion and mobility concerned with the braces. As far as inclusion goes, focus on their abilities. Inclusion is a two-way street, so you have to meet them halfway, and they have to meet you halfway. So it has to work both ways. You can't just have one person trying and the other one not trying. As far as substituting objectives, wheelchair skills for locomotor skills. So what I do, if I'm teaching individuals, or one individual that utilizes a wheelchair, my whole entire lesson plan is changed, and this is for inclusion. So for example, because somebody is utilizing a wheelchair, I'm going to make sure that that the whole group maybe uses the parachute, or maybe the whole group is doing arm exercises or shoulder exercises or scapula exercises, or stuff that involves throwing or catching. And so that's going to be important. because you don't want to have games like tag. And if you were to play a game like tag, what could you do? You could have that individual utilize a noodle. You could give them extensions. Maybe they could hold the rope as somebody else is jumping, or you could have them use their arms in the motion of jumping. But a lot of times, their arms are going to be pretty you know I guess you could say, just taking a lot of work all day. So also I think stretching would be important as well. Make decisions based on assessment data. So, what are you measuring? Are you measuring how much they can pull, how much they can row, how much they can push, how much they can throw, how accurate they're able to throw, and maybe taking those assessment data and using those in a lesson. Make accommodations to ensure success and learning. So, you have to make accommodations, as you know, whether that's using bigger targets, more targets, brighter objects, objects with sounds, or whatever it may be to motivate this individual. And, teach self-advocacy. Let them be accountable for themselves and show them that they need to advocate for themselves. As far as sports are concerned, for individuals that utilize wheelchairs, there are opportunities like events and levels of competition that can be differentiated. There's different organizations like the Wheelchair and Ambulatory Sports and Disabled Sports USA. Wheelchair basketball, there's 8 different classes, and there's higher classes equals greater amount of function, and there's rules. 5 players on the court and a total of 15 points on the floor. Another thing we need to be aware about when working with special populations is diabetes. And so we do see higher rates of diabetes in individuals who are sedentary, and people with disabilities are more sedentary than the general population. We already know diabetes is an epidemic because obesity is an epidemic. So it's important to note that individuals with disabilities are going to have further health problems, or more health problems, than people without disabilities. They're going to have more health problems, they're going to have less income, and they're going to have less wage throughout their lives. So individuals with disabilities have a lot of challenges and obstacles. Type 1 diabetes is typically found in children. You're insulin dependent, so your body isn't able to produce insulin throughout the body from the pancreas. There are insulin cells that go around and transport or help try to diffuse sugar into cells, and sometimes that just doesn't happen. Type 2 diabetes is not always insulin dependent, and that's more related to weight gain, so that's more something that we would see in our classroom, that someone, maybe a youth who is obese, who eats a lot of sugar, that type of thing, and sometimes that's not always insulin dependent. As far as type 1, be aware of the warning signs, and it obviously affects blood glucose levels. Foot care is important, and exercise requires planning, so foot care is important. A lot of people with diabetes will lose function of their feet and have to get them amputated later in life, so making sure that they're getting ample blood supply in the foot. As far as seizure disorders, we haven't had any seizures this year that I know of. Hopefully that continues. But epilepsy and individuals with epilepsy require medication. Some of our mentees we know have epilepsy, and some of them we don't know. Individuals with disabilities are definitely at a higher risk for epilepsy. So this would be important if they're on medication. Sometimes the medication can have triggers, and sometimes exercise can be helpful for preventing seizures. As far as physical education, make sure the condition is not under control. Make sure the conditions are under control. This just says condition is not under control, meaning modify activities for safety, avoid heights, monitor duration, other key factors, and condition is under control, using a buddy system in the pool and using age-appropriate activities. I'm not sure why they did those two types of bullet points. So we're going to go through other special populations that you need to be aware of, such as individuals with asthma, which is on the rise. We know that exercise can be beneficial for individuals with asthma. Sometimes they have inhalers that are on hand. Typically the teachers will have those, and you should know if your mentee has asthma. So second leading cause of death is cancer, and there's many types and symptoms, and it can affect motor skills. So um, this would be considered a disability in some aspect, in that you're going to have some type of adapted physical activity program designed for you. When my father had cancer, we actually had to really put him on a slow, fundamental, start after the cancer. So I see adapted physical activities for people of almost any special population. Like I said, exercise is a key component in recovery. You want to make sure that the medical personnel know that the individual is going to work out again. And physical activity and play are super appropriate for people that are dealing with cancer. As far as cardiovascular disorders, anything that's affecting the heart or veins or the lymphatic system is cardiovascular. And you need to have appropriate prescription movement and general physical activity assessments for them as well, because they're going to be beneficial, and pacing these individuals is going to be super important, and then also getting their resting heart rate down, helping them learn how to pace themselves and not just sprint and then just sit, that type of thing. So really all about pacing, I think, with people with cardiovascular disorders. As far as physical education goes for those individuals, basic weight bearing and large muscle movements, intensity, frequency, and duration are important to monitor and set realistic fitness and movement goals for these individuals. As far as anemia, it is pretty common and affects hemoglobin. It results from a genetic abnormality. You see fatigue, bone and joint pains, and sores on legs are common symptoms. As far as sickle cell anemia and physical education, high level as possible. Modify activities based on any type of symptoms that you see. If there's any joint pains or anything like that, you might want to stay away from those areas. You might have to reduce the impact of the activities, like we talked about with the joint issues, and sometimes hot weather and high altitudes might worsen the conditions. So basically, people with other health conditions will need modifications, and intensity may be needed. Social and physical benefits of physical education must be considered, and avoid overemphasis on medical aspects, and definitely try to work with the parents and the guardians. So let's get into what do we have here? Sorry. Other special conditions, longer-term disabilities and obesity. We'll just talk about maybe some common activity-related injuries that can happen. Ankle sprains, fractures. I've sprained my ankle a couple times. Never fractured my ankle, but I fractured my right tibia, and I've had knee surgery, and I've definitely had the patellofemoral pain syndrome. I do have shoulder strains. I don't have any dislocations. I would say that there is a little bit of overuse of my shoulders from bodybuilding. So, these are common, and many of us have to deal with these issues, and we have to, create programs that are sustainable and not going to make it worse. So, we're always trying to pick apart those injuries and then try to create programs that help them. As far as immediate care, RICE, rest, ice, compression, and elevation, that worked for me. When I had a broken leg, just trying to get the blood out of there, rest, compression, elevation. Definitely after my when I hurt my knee and had knee surgery, these were all really important components. As far as exercises, open chain exercises, so not weight bearing, so like knee extensions with a weight machine. That would be, more important than, maybe trying to load a back squat. Closed chain weight bearing, like a calf raise or half D knee bend, you could also do. So different types of exercises. Isotonic with movement, open or closed chain exercises. Isometric without movement, performing a time bar hang. And then isokinetic, using weight machine with a fixed speed but accommodating resistance so that attempts a faster movement result in greater generation of force, not speed. So these are just types of exercises I'm sure you've heard of. Concentric, which is a type of isotonic movement in which contracting muscle shortens as it moves a resistance, and eccentric type of isotonic movement in which contracting muscle lengthens as it moves a resistance. Sometimes these conditions can cause individuals to be obese, and so these consequences lead to high blood pressure, bad cholesterol, coronary heart disease, and atherosclerosis. I finally got it right. Peripheral arterial disease and intermittent claudation, which is intermittent limping due to muscle ischemia. Other consequences of being obese: congested heart failure, type 2 non-insulin dependent diabetes, being a diabetic, having insulin resistance. As far as your bones, you might have osteoarthritis or in your joints, gallstones, you can get gout, you can have sleep apnea and respiratory problems, and you can have some types of cancer as well. What dietary recommendations can we give people to help promote weight loss? We can restrict calories to 10 calories per pound of body weight. We can reduce intake of saturated fats, and we can increase the intake of dietary fiber. We can reduce or eliminate cooking oil and fat in preparation foods. Like we can avoid fried foods. We can bake instead. We can reduce intake of simple carbohydrates, which would be immediately, if they're not used, they'll be stored as glycogen, and if there's too much glycogen stored, it'll become fat. Use lean meat and trim excess fat from the products that you eat, and really just basically trying to get the calories down. So the reason why there's low-fat diets is because each gram of fat contains 9 kilocalories. So proteins and carbs are only at 4. So a lot of times, if you can reduce your intake of fat, you're going to just overall reduce your intake of calories. Doesn't mean you shouldn't have at least 30% of your daily fat requirement from a daily intake from fat, but does mean you need to watch. Maybe turn that number to 25%. But you still need to get fat in the diet. Maybe just looking for healthier fats and lower calories. As far as physical activity for weight loss, everyone should spend at least 1,000 kcals per week in activities. I do that almost in a day, but I also eat a lot as well, so I try to counteract that. From 10 to 17, frequency 4 to 7 days a week is recommended. 30 to 60 minutes of activity time per day, and the intensity should be 55 to 75% of max heart rate, or about 115 to 145 beats per minute. So that's what working with individuals who are overweight. Alright, so as far as motor development, which is super important, goes into TIE, or task requirements, individual differences, and environmental factors. There's a cool diagram here of a transactional model of causality in motor development and movement skill acquisition, and how people move depends on different things: individual, environmental, and what is the actual task, right? And so all this is going to control all this is going to be your motor control and your movement competence. So basically, your genetics, the people in your life, the school you're at, and then what are the tasks at the school. What are the movements you want to do, that type of thing. There's 3 different types, categories of movement, which is stability, locomotion, and manipulation. Motor development theoretical frameworks are the dynamic systems theory and phases of motor development. Love the dynamic systems theory. which is basically affordances are enabling factors and rate limiters are inhibiting factors. So if you're able to do it, that's going to be an enabling factor, basically, and a rate limiter is going to inhibit what you're trying to do. So something that's trying to take away from the movement. There's phases of motor development: reflexive, rudimentary, fundamental, and specialized. The reflexive movement phase in utero to 4 months, and then 4 months to a year. Rudimentary is birth to a year. Pre-control is 1 to 2 years. As far as fundamental movement phase, initial stage is 2 to 3 years. Emerging stage 4 to 5. Proficient is 6 to 7. As far as specialized movement phase, that transition begins from 7 to 10, application 11 to 13, and lifelong utilization is 14 and up. So basically, the age of 14, your specialized movement phase is at its peak almost at 14, because a lot of times individuals sit until they're 20 or 30 and they lose a lot of the mobility that they had. This is a cool diagram, hourglass of Galou's lifespan model of motor development. Goes from reflexive, rudimentary, fundamental, all the way to specialized, and this is motor control and movement competence. And so, like we talked about, heredity, environment, all plays a huge role in what you're going to be able to do. As far as anything else I want you to know about motor development, I'm going to kind of scroll down here. So rudimentary movement ability, so manipulative, reaching, grasping, and releasing. That's going to be pretty basic, right? So we're looking at these skills because these might be the ones that we're working with for special populations. As far as horizontal movements and upright gaits, that would be rudimentary or locomotor. Other ones for rudimentary could be control of the head and neck, control of the trunk, sitting and standing. Okay, I'm sorry. I should have started right here. So infant reflexive behavior indicating possible neurological development delay, not having a reflex response, a weakness of a reflex response, asymmetrical reflex response, and persistence of a reflex response. So these might indicate possible neurological developmental delays at a young age. Okay, and so basically starting from scratch at the rudimentary movement ability, that's when you're able to control your head and neck, control your trunk, and that's when you're able to sit and stand. And then going into locomotor, horizontal movements, upright gait, standing tall, and then going into reaching, grasping, and releasing, dynamic balance, static balance, and axial movements or external and internal rotations. Then we have throwing, catching, kicking, and striking, which are manipulative, fundamental movement abilities, all the way to running, jumping, hopping, and galloping, which are the locomotor skill components. And then we get into the specialized movement phase, which is transitional stage, application stage, and then lifelong utilization stage. So actually hanging on to what you're learning in your movement capabilities and sticking to those movements. So as far as perceptual motor development, anyone that's going into OT or PT is going to have to understand the perceptual motor process. And if you're going to be in phys ed or personal training or whatever it may be, you're going to have to understand sensory systems. So perceptual motor development, all movement activities are perceptual motor experiences, provides meaning to sensory information, formulates appropriate motor response, and operational procedures include receive, transmit, organize, integrate, and attach. As far as your perceptual motor ability deficits, they occur among many individuals with various disabilities and can include poor spatial orientation, difficulty with body awareness, immature body language, clumsiness or awkwardness, coordination deficits, or poor balance. And so you're going to notice that many of the individuals that we see have perceptual motor ability deficits. And so this can be in conjunction with an intellectual disability and with autism spectrum disorder. As far as in the 60s and 70s, you know, perceptual motor programs were strongly advocated and believed to be a significant improvement in academic and intellectual abilities. Research has not supported this notion. As far as research indicates clearly that the PM abilities might be attained through carefully designed sequence programs. So you have to really sequence these programs like we do in our swimming and in our physical fitness class appropriately. It's fundamental to many motor and academic and functional skills. And so, you know, if you're working with somebody with lower motor abilities, you might be working with grasping, releasing, head posture, trunk control, you know, all the way to locomotor skills at a higher end. As far as a simplified model of the perceptual motor process, so first there we have the sensory input. Major sensory systems related to movement include tactile, kinesthetic, vestibular, visual, and auditory, vestibular being in your ear. So this goes to sensory integration or central nervous system processing, organizing, sorting, and storing information, short and long-term memory, all the way to motor behavioral output, movements such as running, jumping, throwing, tackling, writing, tracking, writing, and so on, and then all the way to feedback. Major sensory systems related to movement include tactile, kinesthetic, vestibular, visual, and auditory. As far as perceptual motor defined, perception, monitoring, and interpretation of sensory information resulting from interactions between sensory and CNS processing occurring at the cognitive level or brain that enables the individual to derive meaning from the information. Motor, the actual movement, response, or act. For example, for hitting a softball, the input would be identify ball speed, direction, spin, and other flight characteristics. Integration would be the information is transmitted to the CNS where it is perceived as a ball to be hit. Output, initiate the appropriate response, swing and hit the ball. And feedback, if the pitch was missed, adjustments to the swing are necessary in future situations. So you're always going through these 4 different bullet points here. When you're going through any type of skill for individuals with these impairments. As far as sensory motor activity, this occurs at the subcortical level and does not involve meaning, interpretation, or cortical level functioning. It involves motor response to sensory input, includes reflexes, postural reactions, and we have different deficits and breakdowns that we're going to talk about. And in this example right here, so this would be an analysis of a prominent perceptual motor need and deficit area. So if the disability was a visual disability, the prominent need and deficit would be to focus on the development of residual visual perceptual abilities and to help the child compensate for visual perceptual motor deficits by enhancing auditory, vestibular, tactical, and kinesthetic perception. Give a particular attention to input and feedback steps in the perceptual motor process. For example, provide immediate feedback such as a beeping sound when a goal is scored. Need to focus on development of residual hearing and vestibular abilities if affected, and help the child compensate by enhancing development associated with sensory systems that are intact. So for the auditory disability, you need to develop hearing and vestibular abilities, right? So you know, how do you do that? Give particular attention to input, integration, and feedback, and steps in the perceptual motor process. For example, provide visual directions or pictures at stations if they're not unable to hear. Okay. So we're kind of always going to look back to this kind of example here: input, integration, output, and feedback during the times that we're teaching this type of motor development. Another example, we'll go over the cognitive or affective disability with intellectual disabilities. You really need to focus on needs determined through assessment of perceptual motor abilities. Involvement throughout the perceptual motor process might exist. For example, provide a positive specific feedback, kinesthetic or auditory, for a skill performed correctly. So we always talk about giving them positive praise and always telling them that they're on the right track. As far as individuals with sensory motor development processing disorders, um, what you want to look at is tactile integration. So activities involving water, sand, mud, and clay, massage, stroking, partner touching activities, barefoot activities, movement education activities, activities performed on various surfaces, handling objects of various textures such as sponge, crawling through tunnels, rolling on a mat, or sitting on a carpet square, tactual discrimination between familiar and unfamiliar objects, including identifying objects, textures, or shapes in a bag while blindfolded. So individuals um, looking to gain sensory or motor development might use tactile integration. And then we have kinesthetic integration, right? So something like Simon Says, moving body parts for purposeful movements such as bending to the right or left, up or down, push or pull, including pulling a scooter board with a rope or pushing a weighted ball. Active movements that develop a knowledge of body parts and their position in self and general space. And has the ability to move different time, space, force, and flow of movement. This would be components and activities associated with sensory-motor development. So as far as vestibular integration, activities involving equilibrium, posture, and balance, including rocking and cradling on boards, cribs, or chairs, simple bouncing activities on spring type or trampoline equipment, simple spinning and swinging activities using hammocks or other simple swing activities on a playground, sliding down an incline therapy ball activities, riding a scooter board, sitting and standing postures, and non-locomotor movement. So putting an individual on top of a parachute and then pulling that parachute will give them a vestibular integration activity. So as far as our next slide here, so we'll just go over the legislation for infants and toddlers. We're not going to get too much deeper into the material, and I want to make sure that I'm covering the main things I want you to know for the next quiz. So as far as legislation, um, the Education for All Handicapped Children Act protects individuals that are infants and toddlers, and then also Individuals with Disabilities Education Improvement Act also helps with determining eligibility and what services these individuals will get. So this eligibility is before the age of 3, and you need to have delay in one or more of the following, whether it's cognitive, physical, communication, social or emotional, or adaptive behaviors. They need to be at risk for delays, or there is a disability present. As far as being eligible or not, a lot of states choose differently or have different protocols for being established, so it's state by state. There's an assessment by a multidisciplinary team, usually sometimes doctors, maybe psychologists, and then there's data obtained and reviewed by parents or guardians, service coordinators, professionals, advocates, others with an interest in the child. So that's all we're going to get for that chapter. And then for this chapter here, I just want you to understand the 3 C's of curriculum design, which are content, construction, and contact. Content differences between preschool and primary ages depend on how well the teacher has examined the assessment information and understands developmental differences. Construction, how the teacher constructs the activity environment and how the activities are introduced differ for preschool and primary age children. And contact, critical to instructional planning, is the thought given to the strategies that maximize engagement with equipment and peer versus time with adults. As far as curriculum organization, their instructional units might be organized around the following: a fundamental skills unit, such as locomotor skills, play skills, looking at themes, whether they're school-wide or in the classroom. Teaching approaches, there's exploration. The teacher selects the instructional materials to be used and designates the area to be explored. Guided discovery, child are presented with a variety of methods to perform a task and then asked to choose the method that is most efficient or that works best for them. So letting them decide what skill is they want to try. So giving them like 3 different options. And movement environments, as far as preschool age, principles of design, child-directed learning, opportunity for choice, self-initiated exploration, mix of novel and familiar equipment, opportunity to view peer models. So I think this is good for all individuals. So the reason why it might be 4 people that are in preschool, but I think this is for all levels, all people. As far as your movement environments, I think this is good advice for everybody. Primary age principles of design. Use a variety of learning styles. So we've talked about physical assistance, verbal assistance, tactile cues, pictures, visuals, sign language. Equipment options. We have so much different options for equipment. So that's we know that. As far as task rule flexibility, be a little flexible when you're teaching. I think we've all had to be really flexible. Use a variety of classroom designs. Lots of designs out there. Ours is different in each lab, so it's hard to say exactly what design for a lab is what. I think everyone understands that their lab is a little bit different as far as their template, how we warm up, or what are our lab activities. And then opportunity for peer observation. So allowing people to come in and watch us, teach, such as other administrators or such as our teachers that actually watch us as well. So we create that movement environment, and this allows other people to see what's actually going on. So if we're still here with me, we're at week 9. You should have posted your field experience updates on the discussion board. So if you haven't already, you can go ahead and do that. Next week, we're going to have our quiz 2. So I went over a quick, brief review of chapters 13 through 22. And hopefully you're going through those chapters as well. You're able to identify, the key components which I've identified today, and hopefully those can kind of stick a little bit. And might be a couple of questions that we didn't go over today, and that'll just try to make sure that you're either reading the information on your own, or there might be something I missed in this quiz review. So make sure that you're being honest with yourself and looking at the PowerPoints, using the PowerPoints for any of your needs or desires for class. So if you have any questions, reach out. As far as future assignments go, we have our quiz 2 next week, which will be posted on Canvas. We'll have our final abstract due the 14th, so that's coming up in 3 weeks. Quiz 3 will be a week after, or that week, and then also our categorical will be in about a month. So that YouTube presentation, if you haven't looked at the information, please do so. And then your field experience hours are due on the 28th. A final reflection, I'll give you more information probably the first week of April. And then our final exam will be on Canvas. All right. So I hope you had a great day. Hope you having a good week, and I hope to see you soon. See you later.